Hey, Anthony.
Hi, so
you said you're just gonna go straight, right? No need for introduction on anything.
Well, just say, I'm sure everyone knows Susan. I'll just ask Susan.
All right.
I'll just do what I can. That's all I can do.
Yeah.
I still have some updates to do to the documents based on what Vishali got working.
Okay.
And I found an easier way to do, maybe an easier way to do a clinical list. There's a whole bunch of different ways you can do lists. So I'm going to show them the easy way.
Oh.
Yeah, but
Oh.
it's do my best.
Yeah.
Hey, Jing,
Hey Susan, how are you?
you're still missed.
Oh yeah. I can't believe it's gonna be 1 month to go live, eh?
I know. I
It's
can't believe you've been gone almost a year.
I know. It doesn't feel like that long, but
No.
wow.
Yeah,
How's it
whatever
going?
we've got. So
Yes. No, I get that. I still don't know if we're ready, but we have to
you know
go
what?
ahead.
I don't think we'll ever be ready, but I
No.
think
Yeah.
one of the reasons we'll never feel ready is because no one really, including us, have had a
Mm-hmm.
great time to be in the system doing
Mm-hmm.
things.
Mm-hmm. Yeah.
And I'm pretty confident that the access will, like, it'll be a slow learning curve, and then it'll be like, oh, people will be just getting the hang of it and
Mm-hmm.
figuring out things and having complicated requests. But
Mm-hmm.
it is onerous. Now when I go back into our pharmacy system, I think, oh my gosh, this is so easy.
Yes. I know. Totally. Yeah, but I think it will come. It just takes time.
Yeah.
And it's just I don't know, for whatever reason people don't have the same ability to access the system as we do now, but in the future they will have to. So
Yeah. Yeah. And I think in the future that will alleviate,
yeah, the
including for
advantage.
us. We still don't have access to things that we've been taught about.
Crazy though.
It is crazy.
Yeah.
But again, as you know, we have zero control over anything.
Yep.
So
Yep.
we
Got it.
do what we can.
Mm-hmm.
But it is very powerful, that's for sure.
Mm-hmm. Yep.
So guys, I'm getting through my first case of COVID, personal COVID, 4.5 years.
How do you feel?
I'm only faintly positive today.
Oh,
So
okay.
I've been feeling better for a bit, but I've still been sticking close to home, which is good that I work from home.
Yeah. Yeah.
That's why I couldn't present last week.
I see.
My sister just had COVID for the first time a couple weeks ago.
She did as well, eh?
Yeah, and she works in like a retail setting, so around people all the time, and yeah, had never had it until a couple
Wow.
weeks ago, and it laid her out.
Mm-hmm. My first
You know
case
what?
was bad.
So I think I got mine from my boyfriend who plays hockey, and because he was a bit sick, but he did his test and he said it was negative, but then he showed it to me later and I could see a faint line, right? And then I did my test and it was like, oh yeah, the liquid barely got there and it was turning dark. Yeah, dark line. So it really, I think I got affected more than him because I have zero natural immunity. And I had gone to KGH to get my shot and it was not available. So I was meant to go back.
So you weren't vaccinated? Yeah. Okay.
No.
Yeah.
I go for the natural immunity. Hey everyone, all my buddies. Anthony said, do you want an introduction? And I said, yeah, I don't think.
No, I don't think you need.
We good.
We good. We good.
Not only have you been on these meetings before, but I'm pretty sure you have worked with anyone that has not been in the meetings. You have just worked with them. So. I wanted to share quickly with the group. So today we had planned a 4-hour meeting with everybody. So a representative from our super user from all the different clinical areas, nursing, physician, everybody. And we tried to run through a patient from start to finish. And we actually had like 14 scenarios we wanted to do, like 14 different patient cases, 4 hours to do one. Yep. So in case anybody's thinking about it, that you want to run through a full patient, like start to finish and have like your whole team there, it's so many problems because we built the first case of the patient comes to emerge and then they go to the OR and then they go to the floor. And that's like a totally normal thing. And it took so many pieces just didn't function properly in trying to move the patient and the documentation and all the pieces to flow. I know some of the hospitals asked, like some of the health records people were asking to like sit in on our thing today, and they were told like maybe you should just run your own. But in case you get asked, it was very helpful for all of us to see the kind of the start to finish, because no one's ever seen the start to finish, but it was not successful. And this is like including, I know some of you know Marie France, who's like the most amazing clinical informatics person I think anyone has ever worked with. And if we could clone her, we would. Just problems everywhere. So I don't feel good, but hopefully, so Marie's probably just going to continue working 20 hours a day and trying to get it all to work. But in case you're asked to do it, I think, or have a pharmacy person involved, I think it would be very worthwhile just to see it and be able to do the pieces in the exercise.
That's interesting, Anna. I did an ER simulation today and similar thing. We just did emerge. That was it. Just one emerge patient. And I learned a lot of things, and the things that they were saying, I was like, that is not going to work for pharmacy. They wanted to document all the meds in their notes. And I'm like,
nope.
I don't think that's going to work.
Doctors or nurses? Okay, yeah, no, the nurses are not. No, the nurses are not. And then our doctors currently do. So that's because we have our nurses do separate charting. We've actually had over the last couple of years, I've had to fight with the docs because they wanted the nurse. So the Meditech chart is the source of truth, but they wanted, because they still write their orders on paper, even though everything else is electronic. They wanted the nurse to document meds given on the paper and in Meditech. And I'm like, no, this is it. And then we actually had a med incident. I said, no, they're not doing it anymore. Meditech is the source of truth. And we made like a shortcut for them to find the documentation. But I'm like, they're not doing this anymore. And that you expect them to document in multiple places is a safety issue. But yeah, no, it does not go in a note. No, my nurses are very clear. It does not go in a note.
Yeah, they know that now.
Yeah, good for you. Like, no. It's going to be very painful. The emerge departments, it's going to be very painful.
Anthony, do we have anything besides me today?
None.
No?
I don't know if you want to start or you want to wait for Nelson and Charlene.
I guess we can talk to Jacqueline. Hey,
Sorry,
Jacqueline.
Jacqueline.
Hi. I'm the bearer of bad news. There was something. I just wanted to bring up, sorry, my camera doesn't seem to be working. Here we go. There was an email that went around, that came to me from one of our change managers, I think, about the antibiotics, the IV, I think, sets, everything is in D5. And I don't know what meeting that was decided at. I certainly don't remember, but I am concerned about that because that means our pharmacy staff is going to have to flip everything that we don't put in D5 out of D5 versus the order string being done properly. So I don't know. I did talk to Anna and Sherry, and neither of them recalled making this decision either. So I'm just wondering, I don't know when it was made or, you know, but it is concerning because a lot of our stuff is in saline and not in D5.
And unfortunately, especially for Emerge, everything is auto-verified and the nurse can't just change it. And that actually is also an issue because nurses can administer something IV push or in a mini bag, and everything is built as mini bags, and then they can't bypass it. So yeah, I don't know if there's anything we can do about it right now. And I don't know, apart from changing all the orders, I don't know what you can do. Or I don't even know if you can have, like, I don't even know if the doctors can enter it with a different bag.
So I think Charlene, she's not on, no, she responded to that we can talk about it. I can tell you from when I joined, we were advised there should be a regional decision made. I think Robin provided that advice to us, but I don't know when that was actually done. So it was, the build was done based on the DCW that was available at that time. There was talk about building everything twice, and it was determined there wasn't enough time to do that. So I guess the thing is we have to decide what we're going to do at Go Live. As you guys said, what do we do when they want a different diluent and when they want to do something IV direct? I have some ideas about what's going on and how to mitigate it, but I did see Charlene said we might be able to add that to another meeting. So I'm going to let her take that as workflow lead. But I can talk about pharmacy clinical surveillance rules. Okay.
Well said, Sue. Thanks.
We're in this together. Like we will get through it, but yeah, it's going to be challenging for sure. So the reason I'm doing pharmacy clinical surveillance rules is because they were set up as antimicrobial stewardship rules in Cerner. And so I was involved when I was a SME looking at them, but there are a number of rules in there that are not antibiotic related. So we changed the name to pharmacy clinical surveillance rules. So what I'm going to do is I'm going to share my screen and go into the domain as a pharmacist. And this is the way that I go in. So it's at the access to the tool, I would call it a tool, is through PowerChart. And depending upon how your little icons up here are ordered, I find often you have to go to the tail end to find this PCS work list, okay? So that is what you're looking for. I'll just reorient you to, this is the pharmacy patient monitor, which is on that top bar where you see orders coming in for verification. And then I believe Charlene was talking about the multi-patient task list, where you had your consults and interventions stored. And then there's other sorts of lists, and I can tell you I'm sort of getting oriented to them as well, but you can make your own sort of patient list. And there's also a clinical work list. I can tell you they're all integrated, but today I'm going to focus on the pharmacy clinical surveillance work list. And if we have to, we can go backwards to see how it integrates with the other lists. So what this tool is it takes various fields within Millennium and looks at drug orders, often looks at drug orders, and sometimes the order in which drug orders happen with respect to reporting of results, like in micro. And if it meets certain criteria, it will fire an alert. And what the alerts look like are right here. They're quite vague, I can tell you, which is why I gave you our first draft of our background information on what they mean. This does not put anything on the patient's chart. This is an alert to the pharmacist to say, think of it as like your pharmacist at the desk reviewing orders. Hey, I think we need to look into this. So it's truly surveillance. There's no action that's done on the chart. Anna?
Sorry, because I just have CERT open for a different reason because I got to do chemo testing. Is there a way to pull up your PCS, your list that we can do?
I'm not there yet.
Okay, because I was
Yeah.
like, I was just trying to follow along, and I'm like, I went in and it started asking me all these questions. I was
No.
like, what?
It's not intuitive. Not intuitive at all. So I'm going to show you how to make a list because it probably came up blank for Anna because you have no patients that it's looking for yet. But I just get back to it like this. Think of it as sort of your person on the desk that says, hey, can you look into this person? And the only thing is that in the background, the computer is taking some fields from temperature, micro, drugs, age, creatinine, and looking at them to see if it satisfies the criteria and fires an alert. The red ones are identified as a higher severity. And it'll show top two, but if you click on the alerts, it will actually drill down into how many alerts on this one patient. And it will tell you when the alert fired. I'm going to say vaguely, it tells you why it fired. There's not a lot of information on there. And if you look at the history only tells you about who looked at it. So I can show you. Right now it says not reviewed because no one's looked at it. But if a pharmacist goes in and says, oh, I'm going to look into this, then under the history, it will show that I touched it. Right there, I changed it from not reviewed to in progress. So that's all that the history does. Okay. And the idea, again, surveillance, is you would take whatever patients you want to look at, which we'll get to, and you would go through and say, yeah, I don't care about that. I'm going to dismiss it. I'm going to look into this, and I think they need an intervention like a TDM level, Anna, warfarin, INR. Or I leave it not reviewed because I just don't have time, or I just want to call it completed, get it off my list. It will still identify itself as being triggered for this patient, but it will not appear as not reviewed again. Okay, so how do you get your patients? So I'm going to say this a couple of times because it took me a couple of times. In order to build a list, you have to click on filter lists. It doesn't really seem that way, but you do, because as soon as you click on it, it opens up this screen that says, hey, create a new list. So on behalf of Jacqueline, I'm going to create a new list. I'm going to do create new. It's an untitled work list right now. It will sometimes take a while to come up. Jacqueline, is it Smith Falls or Smith? It's Smith Falls, right?
Yeah, there's an S.
Oh, there is. Okay, good. I should know that. So I'm going to name it. And then I can either populate it from a patient list, and that's one that I've made up here. And I think I have a Quinty list made. I tend not to use that, but let me see if it'll come up. Yeah, so I have a Quinty Health list made, or you can do it by facility. I find facility is best. And here's another hint. If you do search, nothing will come up. You have to actually start typing something in. So, and then you have to figure out, okay, how did they actually birth Smith Falls, I think. There it is. And then this is the facility that I can pick. So I'm going to pick Perth. Then I could go down if I wanted to narrow it. Here, I could only select certain units, certain medical services, encounter types. Status, I only want to see ones that are not reviewed. Types, here's all the types of rules that will fire, and we'll go briefly through some of the logic of those, but my idea is to give you a reference of how they're pulling these things. But you can see there's some there's only so much real estate, so some of the names, I can tell you we inherited a lot of the names, so we have what we have at the moment. And then you can also have a mild severity, moderate, and severe. If nothing is clicked off, then you'll see everything. So I'm going to start with that, and I'm just going to say save. And then I go down here and I generate my work list. So it's bringing up now all the Perth patients with things. And I haven't done a lot of testing in Perth at the moment in this system. Most of our testing took place before they took the cert copy. The reason all these I say RX consult is because there is a rule that places a pharmacy consult if the patient's been admitted for longer than 90 days without a med review. So that's all those people. Here's one that says dual. I click on it. So what happened is it looks like, and again, I can't really discern why it says just warfarin. It might be 2 warfarins, but what this is telling me, maybe I should look at it. So again, it's surveillance. You need to look at it. Here's another dual one. Let's see. I have seen some. So this one, is this the same person? No, it's not. It might be 2 biosimilars. It gives you an idea what the drug is, but it actually, you sort of have to see the patient. So what do you do to see the patient? Well, there's a couple of things you can do. You can just click on this person. Anytime you go into a person, you're going to say who you are while you're in that. And let's take a look at their med list. Yeah, so there's a lot of stuff going on here in terms of anticoagulation and antiplatelets. So what it's doing is it's drawing your eye to this person to say, hey, take a look at them. So let's say I wanted to do something with them. I can still sort of do it from this worksheet. Right now, all these spaces are blanked because I haven't established relationships with these people to see what is in their chart. If you go up here to this layout configuration, I can have this real estate populated with a number of details. And apply. And it will stay gray until I say, yes, I want to be assigned as pharmacist to all these people. Submit. So this might help me figure out who to look at, what kind of data is available. This actually tells me the number of unverified orders. So this is usually available again in this pharmacy patient monitor, but I could, if it was my patient, I might be able to just go in there and see what orders need to be verified. Medications. It just tells you that they exist on the chart. So the patient does have medications. If they had micro, it would appear here, but I don't see any micro right now. And again, I'm not quite sure the filtering, is it just within the last 24 hours? Is it within the last, here's some creatinine. Let's see when this creatinine happened for this person. If I click on it, it was pretty recent, November 5th. So I have a feeling this is recent labs here. The other thing it has, and it'll only show show so many columns. I'm going to take some off just to show you some columns that I played with. Should say by that. Forms. I played with forms a bit. So forms, obviously, it's just like documentation. So if I click on forms, it tells me there's no results found for this patient. So there's no documentation found at all for this patient. But if I wanted to create something, I could do one of these forms. Now, this one was in there from model. We have not evaluated it. We left it in because we think Heather and other centers might find it of use at some point to document what type of intervention is being made on this patient from. It's not really, think of it as an easy way to access an intervention form. It doesn't really link with pharmacy clinical surveillance, but we think it might be useful in the future. So we've just left it existing. I can tell you that when you have forms like these, they're called power forms. They're useful for running reports as opposed to if you put things in with text. You'll find with Go Live, we have a lot of text because we really don't know where we should put time and effort into making power forms. I haven't done my power form training yet, but it is time and effort to put them in. But the reason why this might be useful is in case Heather or any other center that is doing more detailed reports about stewardship might find it useful. We will have to get some data in there to figure out what the reports look like. And I'll always remind you about forms. You can have different pages of the form, so you can look at different things there. So that's one of the forms. But the one that I can see maybe being used initially the most would be just clinical information, intervention, which you should have seen before, where you identify what kind of intervention type you're doing. Again, you have to type in the order. You might want to say, based on clinical surveillance rule, firing there, and name the rule and document this form on this form. And I don't know if we've gone through this yet because I haven't been to all these meetings, but you can also do your workload stats here about attendance, like in front of the patient, and pharmacy workload assessment and the number of minutes. So while you're doing the intervention, you can also do your, in my head, I call it emeralding. So you can do that just when you do the intervention as well. You can do it separately as well, that the separate is right there, which is essentially that second sheet. So we have alerts firing for my patients, and we have some data to figure out, again, just to go look at the patient with some vital information here that may help you. I'm going to give you some other types of rules. So I made this list. I was trying to find rules that have been tested. So here, this one comes up a lot. I want to establish relationships to get more data coming out here.
I see there's a couple of hands up, Susan. Do we want to pause for questions on any of that for a second?
Yeah, I do.
Hey, Sue. I was just
Michelle.
wondering, for these clinical surveillance, they're automatically generated by this system, right? No one can put in, like when you said that DOR could kind of like flag you, no one could put these in. They're just system based. Is that correct? Or is there a way to actually flag someone to look at this through this system? I know there's other ways with the other parts of the system, but these are all system-based alerts, right?
They're system to all pharmacists. So depending on which ones you see, you have to go looking for them though. They're not going to pop up unless you have that patient, you're looking at that patient. I think the idea was that you would use the multi-patient task list.
That makes
Right?
sense. I just wasn't sure if
Yeah.
those are automatically generated or we could actually generate one of those flags for a patient if we wanted someone to look at something, but it doesn't sound like that. It sounds like it's all system based,
No.
which is fine. Okay, thank you.
And then the other thing, because I'm envisioning how this would flow as well, I was thinking like there's not a huge amount. As soon as you do a clinical intervention on the pharmacy clinical surveillance rule list, I think then, and I don't know if Charlene's on there, I haven't tried this, but let's say I did do a form of clinical intervention. Could I not sign it and then it would go to my multi-patient task list for follow-up? I do know you could use this this filter of you could look at your patients and see what you closed and what you didn't close. The other thing, there is this filter here if you're looking at one patient that you can just put in a patient name. And it should, I'm trying to think of a patient, I think it's SADC. Oh, there. So you can put in an actual patient's name to isolate as well. So if someone said, hey, can you look up whatever patient, you don't have to go through a long list. You can actually put in the patient name and take a look and see.
Sue, just to follow Michelle's question, so do we know exactly what will trigger these alerts? Like, is there a list of, I guess, a list of alerts that we're expecting? And I guess the reason I'm asking is like, just for like our inpatient high dose methotrexate, for example, like is there going to be an alert in this view that would come up for like, oh, it looks like their methotrexate level is like at a 4 where it should be a 0. Like, will that alert?
Yes.
Okay.
So so what I did is in an Excel together with help from the Neha, Anthony, and Nahi, is we summarized the alerts, and it should have been attached to the agenda.
Oh, sorry, maybe I didn't get to it yet.
Because the other thing to remember, it's a computer, so it's very specific, the drug. So if we get another anticoagulant, we have to go in and rebuild this rule. Okay, so this is, I'll
Okay,
just note
gotcha.
for everyone, this is, can you see my screen? Can you see? I don't, maybe not here. You see my screen now with all the alerts? Okay. So this is draft 1 because we're going to, some of the rules, we've been doing extensive testing and they just aren't firing. And if I go live, I'll tell you what we're moving to optimization to work on. So this is the name of the actual rule, which will come up in, I'm trying to think if it'll come up here. Yeah, so it sort of matches these names here in terms of the rule. This is the purpose of the rule. So this one, 2 times anticoagulation, is to alert. And in this case, the clinician, we decided nothing to fire to the physicians at present. So they're only firing to this list for the pharmacists. If there's 2 orders placed for anticoagulants and you may require therapy evaluation. So the computer wants to know, hey, what do you want to look at? So these are the ones that we've identified. And what the alert category will be is dual treatment, and the severity will be moderate. Okay, so there's a number of them that are, you'll notice, are for escalation and de-escalation. So you can imagine what can happen with an antibiotic is you're on the drug and then you get a sensitive culture result. So you want to be notified. Or you have a sensitive culture result and the provider tries to order a really broad spectrum drug. So that's why you'll find some of them are reverse. It depends on what comes first, because again, it's computer, it's very logical. And this is when it will fire. If there's a blood culture and there's a gram-negative rod that's sensitive to cefazolin or AMP or Moxclav in the last 7 days, and this is ordered, and what does this mean? It's one of those drugs. It will fire. Okay, so I think the idea is to always have this reference list until we get more idea on what it means when you have these types of things fire. There is and I'll tell you sort of the themes of them are de-escalation, C. diff positivity. This is one we're having a hard time with, QTC, if they're on an antibiotic like a macrolide. And one of the reasons is the QTC is coming from EKGs, which have to interface with the system. So I don't think our Oracle Health person has been able to figure out what field to put it in the rule yet, based on Lumio customization. I'm trying to find one that's not antibiotics. There's a lot of anticoagulation, so if they're ordered 2 of these drugs on the right-hand side, if they're ordered an anticoagulant and an antiplatelet, and I think we have, yeah, anticoagulant and an antiplatelet, 2 antiplatelets. This one you're going to see a lot, and it says severe. It came with the package, we left it, but if you wanted to suppress it, it's basically they're given an antibiotic and there's no culture on file, which is probably going to happen a lot. It's supposed to be no culture in the past 14 days, but of course, if they're just admitted, that might happen. But again, you can filter and not see that at all, or that might be, hey, they're on an antibiotic, and right now, what are they going to treat? We tried to narrow it down to these antibiotics, and that they haven't been doing, like, there's not a blood culture pending. Like, truly, it should be. We're trying to refine the rules so that it really alerts you to, I guess, the most important things. Let me just see here. Days of therapy of on antibiotics. So if you're on any of those antibiotics for at least 7 days, that's what we're going live with just 7 days, it will flag for you. They have this built if you're on Tamiflu more than 10 doses, if you're on Vanco for at least 7 days. This one was interesting. It looks at the fact that you're on one of these antibiotics that could be given orally, and you don't have any vasopressors or antiemetics in the last 24 days, or sorry, 24 hours. And I believe you're afebrile and you have a dietary route as well. So it's really trying to incorporate already logged fields, fields with clinical data in terms of flagging things. Here's the methotrexate. So when we first had it, we did this modification. It just said, put it on the list, the alert, if it's greater than, I think it was 0.05. And we said, no, we want anyone to be reported because we don't want to know what it is. So I think, Patricia, that's what would be valuable to your team. This is more about glucose monitoring. If there's if they're on a long-acting or intermediate acting glucose and the morning glucose is low. This is a creatinine result greater than 25% or less than 25% in the last 7 days. And one of the anti-infectives that's being ordered, and we'll populate that with the antibiotics that are coming. And it's not like I'm writing these right now. They've already been written. I have to find the tables where all the data is listed. This one is surgical prophylaxis. So they've been on surgical prophylaxis for at least 24 hours. And it'll come up with this code, surgical, I don't know why it says SCIP, mild. This one's interesting. So it's bug drug. Oh, they should say drug bug. So basically, it's your mismatch. Your bacteria is resistant to the drug you ordered, the bacteria you already have in file, or the drug you ordered has now been shown to be resistant to a new culture. And so it will come up as mismatch severe. This one is, and again, it's non-susceptible. And we're trying to really focus on things that you would be treating. There are urine ones on here, but I haven't really delved into them very much. Partly because you can imagine to test these, I've had to take a lot of time out of the lab people. I do not know how to result things right now. And so they've been very helpful at doing the ones that we thought were most important to make sure that they fired. Here's a phenytoin level. So basically, here it's less than 20, greater than 40, and they have to be over 14. Here's a positive culture, and there's no antibiotic. And you'll notice it's only these, it's not urine. Here's restricted drugs. Any of these drugs, they'll populate to the list as restricted. This one, I think this one's from my older days of safety of daptomycin. Anyway, if you haven't had a CK done within 7 days, TDM level, we're working on this one. They originally had it for only if it was low or high, and I said, no, it needs to be for any. And I do think it's working now, but I have to get the lab to do it, place the actual result. There's some urine things, de-escalation of pip-tazo, weight change. So if there's a 20% weight change, And it's an inpatient, and the patient's 18, and there's a medication order placed. So that's up to 55 right now in terms of what is built in the system. So then, and I'll send this out to you again. These are samples, and I'm going to try to put them beside each of the ones that's relevant of when we were testing what things would look like. So for example, here's a mismatch where the patient's on Vanco and the urine grew vary. I'm trying to find it. There's a restricted medication, daptomycin. There's a Tobra. Here's a weight change, tells you before and after. I'm finding that the fields it's pulling from is only the numerical field. It's not the unit field for a lot of these rules. Okay.
Susan, Rasha has her hand up. I don't know.
Hey, Rasha. You have a question?
Yes. Hi, Sue. Thank you.
Hi.
This is wonderful. I just wanted to make sure I understand this correctly. This is basically a target list for the clinical pharmacist. When they come in the morning, they know how to prioritize their patients. So I'm following through with you. And when we go to the alert, selection of the alert, do you have a choice to customize of what type of alert? Like, for example, the ASP pharmacist is going to look at certain things in the hospital versus the ICU pharmacist maybe looking at. So, okay, yes, you can. All right, yeah. So all the stuff that you went through, you can actually select yes or no. That's very good. And
yeah,
it is.
So if nothing is selected, it means it's looking at everything.
Oh.
But as soon as you select some, you regenerate your work list.
Yeah. It excludes it basically, right? Exclude that.
Right. And again, if you want, you can just do the severe ones as well and work your way down.
Yes.
I think it's because my list is so big, it's taking a while to generate. And then you can create like your own little lists here as well. This is all individual, by the way. This is not shared. Everyone has to do their own.
Oh.
So, you might share a strategy on how to build a list, as a clinical manager or supervisor, but every individual pharmacist has to do their own. The other thing I would say this would be the third thing you would look at when you come in. So as Charlene went through, and again, we're showing you the tools, and even myself being a clinician for like 35 years, I'm not really quite sure how I'd use this plethora of data myself. I think I do a lot of trial and error, but I really think I'd come in and start looking at the patient monitor and see what has been in the queue, in terms of verification, what's urgent. And then I would look if I was being on reviewing orders on a certain service, and I can even pick a patient in here and I can set a view for a certain floor as well. Then I'd probably look at the multi-patient task list, because then, there's all the active consults. Is any of that for me to look at? These are the active interventions. Are any of these mine that I'm working on? Are they in process? And then I'd probably go to PCS.
Okay.
Charlie, do you know how to reorder it so the PCS is over here at all, so it's more visible? Is under preferences?
When you say reorder it, so you can't
Resequence.
You can't make the columns any shorter. They are what they are, especially if you've got multiple things that you're trying to pull in. The system only has so much room, and it doesn't It doesn't work like an Excel spreadsheet where the more columns you add, you can scroll over. It just makes all the columns that are there tighter.
Right. No, I meant this, how I can get, because this is CERT pharmacist, is there any way we can make the, like even inventory management and PCS work list on this toolbar instead of like message center?
Yes. So from my experience using the system, the more you use the application, it'll automatically populate to the top toolbar, and it'll move things that you don't use over into the hidden icon.
Okay.
Yeah, and there's other lists to the clinical work list and the patient list, and some of them you can customize, but I think people maybe when we go live, they're gonna be able to try and do trial and error and find out which one more useful for them, or do you have an idea?
I have an idea, but I'd like to try it before actually sharing it because I don't want to confuse people. I know there was a question that came through about what this dynamic work list is. I have no idea what that is. Charlene, do you know what that is?
So the dynamic work list is generally used by other disciplines. We used to have something there instead of called pharmacy clinical surveillance. It used to be called pharmacist work list, unfortunately, and it would do some of the things that the clinical work list would do, but it was designed to only show specific things like BPMH, how many meds a patient is on, whether MedRec was completed, and things like that. However, during the project phase, it wasn't working correctly, and I don't know if Hosam is still on, but it wasn't working correctly, so we turned it off. And because the pharmacy clinical surveillance piece was being developed, we just didn't turn it back on. So the dynamic work list is used by other disciplines, not pharmacists.
So you brought up a good point as well, Charlene. Let's say the pharmacy technician coming in the morning and she want to know what's her list of patients that haven't been done. Is the computer able to generate something like that?
Not current functionality, no.
Because some systems, I think Meditech was able to do that. Yeah.
And that's where that other workflow page, the pharmacist workflow page, would have been beneficial to have that, but it wasn't working.
Okay.
So it could be something that we look at for optimization. The best bet would be your technician would look at the patient list, and they would identify who the new patients were based off of that patient list, because it tells you when those patients were admitted. And if it's the same technician who was working on the unit yesterday as today, they would know who they saw and who they didn't.
Yes, and normally we use a different process. So you actually go through the admission list and do that, but it would be much easier to, if it's already ticked off, it's completed, then must be a way to create that. It's fine. We'll continue doing what we're doing.
Okay, I'm going to do a couple of questions here. How do I make a new work list? Can someone, or a new PCS list, can someone walk me through it?
Well, this is Rob 8. I was able to find it, and I was following through with you. So yeah, you go right. Are you testing us right now or what?
I'm testing you guys.
Okay.
But keep in mind, like any good clinician, anytime you test someone, you're testing yourself. You're like reinforcing it for myself. How do I?
Yes.
How, if I wanted to do a Providence Care work list, how would I do it?
Yeah. So here's, I'm gonna be cheating right now. You log in to PowerChart, and then you go on the far side of the toolbar. You can see on the right side, but you can see which icon, and then you would click on PCS work list.
Okay.
Then,
And what if nothing comes up?
well, then we call you and ask you why it's not coming up.
Okay, so I'm gonna show you actually what it will look like. I'm gonna delete all these. And
Sue,
this is
Sue, I have a
not-
question just looking
Yes,
at it. Is there an
sure.
explanation page of what all the alert types mean?
There is only the document that we're putting together, that summary list.
Okay.
Okay, so once we finalize it, I will share it, and I'm still not quite sure where we're keeping, reference material, because obviously with every formulary change, like even I think Dalbavancin went on formulary some places, like I'm gonna have to update the rule. And so there's gonna be a number of rule updates. Yeah. And I'm trying to not commit them to memory, but it is my reference material. If something doesn't fire, I always go back and look, okay, what did we want to fire? And then look into it. But I am finding, like, even you can imagine with micro, you can have a C. diff infection, you can have C. diff colitis, you can have C. diff alone, you can have Clostridioides difficile. Like, there's so many ways in the lab they can name it. It's all integrated. So, all right, so you're going to go into PCS, and it's going to look like this. So how do I make a list?
You filter. You hit the filter
Yes,
list.
yes. And it's so clear, right?
Yes.
It's so clear. Okay, so that's the key, is just anyone you can spread the word, and then we'll just do list.
We created a binder for crucial job aids, and actually it seemed to be very helpful, especially in the beginning. Here it is, and then you create new. You hit the create new on the top left there.
Yes.
And you enter a title like you did for Persimisfol.
Yeah, so if you go like this, nothing will come up. And I found this a couple of times in the system. So always just try doing a prompt. And you don't know, is it going to say PCH? Is it going to say prop care? Is it going to say whatever? Just try a few things. But there, I will save, and then I generate the work list, and it should populate. Oh, no, I have to.
No.
Oh, no, there it is. Yeah, there it is. Okay. And then again, if things are gray here and there's data, it's probably because you haven't established a relationship to see the data.
So every pharmacist who comes in the morning, so each pharmacist may create their own thing, and therefore they are going to create a new work list under that facility.
Well, and I think, what I would probably do is everyone has their own things that they usually cover. Could be the whole hospital, like for a weekend. It could be, oh, I'm just covering Davies 4 ICU, or I'm covering Quinte ICU. You can make as many work lists as you want, so you can go to whoever's registered in that area. I tend to do it by location. I find services a little dicey sometimes. So, but I think I'm going to be coming back to you guys in about 6 months and say, okay, how is this best working for you? Because it will be a bit of trial and error to make sure you're looking at the patients you want to look at. I know you can look at them. It's just what is the best way to do it. And then this is where doing some reading more about creating, like picking a patient list. So I did a patient list using this feature up here, Quinte. And it will come up here. And this Quinte list can be very refined as well. It could be, oh, I'm only looking at 4 beds. I just happen to name it Quinte Health. And I think we can help you you know, if you help but describe what kind of patient population you want to look at, we can help you set up a list. Okay.
Susan,
Any other
there,
questions?
yeah, there were a few questions that came from the Lumio library, and I apologize for jumping on a little bit late, but I'm wondering if we could just take the next couple of minutes. You may have addressed these in your presentation. And so whichever org was that asked them.
There was one that I was going to address, and I can do it quickly because I think everyone, if they haven't seen it, would be interested in it. And it is bringing in data from the chart into documentation. Have you guys gone through that yet? Like how you pull in a creatinine?
It was in the training, I think, but of course we forgot about it.
Okay. Well, I can sort of show you quickly, and we can expand upon it potentially at some other time. So if you have a
Yeah.
I think you have to have an editable maybe we'll do it another time. You have to have an editable area of your document, and then you can bring in what they call tokens into your documentation. So it would give you your med list or something like that. So including microbiology. I might have to get it better set up to show you, but that was one question. And how to save auto text is useful as well in terms of doing documentation. So it can flow from rules, but it's not necessarily specific to pharmacy clinical surveillance rules. The real takeaway is it's to identify patients that you need to look at.
There was a question about status selecting under the dynamic work list or PCS work lists. Do you know if that was covered earlier?
I think I went through what the meaning of status was.
Okay.
But again, I don't use the dynamic work list, so I don't know that that's
Is there a status in the PCS work list?
There is a status, but it only goes to the type of alert. Like, is it in progress? Is it dismissed? Is it completed? And
So
I will, sorry,
yeah,
I
go
will
ahead.
say if you do dismiss it, there is a drop down that says you want to dismiss it just for like 24 hours. Like, for example, they could have more mismatches within an encounter. So you can dismiss it for 24 hours, and if it refires, it will fire, or you can dismiss it for the whole encounter.
But if you complete it, it will fall off.
Complete it will
gone
fall
from the
off for
list.
that. Yeah.
Yeah, I think that might be what we need to know. Like, what does each status mean when we're
Okay.
selecting them? I guess
I can
that's
put
probably-
that in this document then.
That would be helpful. Yeah.
Yeah. Obviously, I'll be really interested in knowing, and it's probably going to be through a ticketing system, of any people that you're wondering why rules didn't fire for, why they did fire. Like, honestly, I keep thinking of it as soon as we go live, it's phase 4 testing. Like, we're going to find things that we've tried to do our best with doing initial testing, but real life is where it helps. And obviously I'm really pro. I want to learn how to write rules. I imagine that's a steep learning curve, but I think there's a lot of power for systematically identifying people that need to be looked at.
Awesome. Thanks, Susan.
Yeah, sorry, Charlene. Okay.
Yeah, go ahead.
So, so just want to go through some questions, or all the questions are done? Is there any other question? Oh, Charlene?
Nope, I have no questions.
Okay. I think with that, we've come to an end. So next week we're going to go through some few demos and few other questions from the group.
Yeah, I guess are we going to address that diluent question, or even get a strategy for it? Because it's.
Can I
Okay.
ask something?
Russia?
Suzanne, I just want to ask about the same point you wanted to bring up. When the pharmacist is processing the order, they have the choice to select the diluent, right? They can switch it off. But the issue is, if all these antibiotics or medication are ordered overnight, or there's no pharmacist to review it, the nurse is going to go ahead and mix it in the whatever D5W is there. Then in the morning, the pharmacist is going to switch it to the normal saline, right? So
Yeah.
if this is that something that can be tolerable until this gets fixed, because obviously it may not get fixed right away, that we have a good understanding that pharmacists are going to always have to switch that. I know it's going to slow us down, of course, and until this gets fixed, whenever it's can be done.
Yeah, I think it might be good if we come up with a strategy, like how we're going to optimize it, and let everyone in, because it affects like all clinicians, nurses, and that. But I don't know that the answer is always going to be having it mixed in both, because even coming from an order set perspective, that mean you'd have everything in everything twice on order sets. So I think we really have to take a hard look at how we can approach it regionally to make it work with our new system and for all the local institutions. We will not have it done by go live. It's very pervasive in everything that's intertwined within the system, but I think it's really fair to have a good strategy going forward. And I do think our working strategy is to have at least one in the system to do exactly what you said, Rasha, is we had to test it, build it, test it, make sure it worked. And now we can maybe think about, okay, what diluents, because I know Ringer's lactate has come up in a couple of situations too.
The
Justin?
default usually is normal saline. So the default usually is normal saline. I don't know what others.
Yeah, not at every institution.
Oh, okay. Go ahead, Justin. Sorry.
Yeah, I was just going to talk a little bit about this because we've started to have the conversations here at PCH. So we predominantly use normal saline as our diluent for intermittent infusions. We use a lot of mini bag pluses as well, just because we don't do a ton of different, piggybacks. So that is what our nurses generally use. So really what we've spoken about is, number one, make sure that everyone has the D5W on their units in the 50, 100s, and 250 sizes. There's also the D5W mini bag pluses, which could potentially be ordered in if nursing wants to go that route later on. But the way that we see this working is that we'll probably just leave them with the default IV set information, D5Ws. Nursing can change the diluent at the time of administration, as far as we're aware. And then if they need to, they can submit a med request to pharmacy. And then we can look at changing, the actual IV set out it's not as easy as in our current system where we just quickly, replace the constituent. It's probably just more of a familiarity thing with Cerner, but we can switch it out at that time because clinically there's probably not a big difference. It's going to be whatever nursing is going to want to use. So we'll let it be driven by a med request process. And prescribers right now in our current EPR do not specify the diluent at all. We've never seen, very rarely will we ever have a request to change someone from normal saline to D5 or vice versa. So we've just kind of let our physician champion know that if they, want to do something, they can put that in the order comments or in the order somewhere if they want a specific diluent. But we're just kind of leaving it at that. I haven't really heard back yet from nursing in terms of what the strategy is for them to communicate out, but I think we'll just probably communicate it that at least for go live, the default diluent for, intermittent infusions is going to be D5W and see how it goes.
So are you describing right now your current status in QuadraMed or what you have educated about the Cerner? Like your future strategy or your current strategy?
Well, the communication would be like our current state is this, normal saline, future state, the default will be D5W. If you want it changed back to normal saline, for example, to use a mini-bake plus or a clinical reason, you need to submit a med request for pharmacy if you're a nurse, or if you're a prescriber, you need to put that in the order comments.
Yeah, until it gets changed. But I think regionally, could we agree when we are making in the optimization or whenever, could we agree that the default be normal saline and would be a med request to change to D5W when needed? Would that be reasonable?
Yeah, that's a bigger discussion for sure, but we're just kind of preparing for go live right now.
Okay, I see. Okay, yeah, I agree with you. I think it's very reasonable to do that. Would that be through a memo or professional practice discussion and then they take on the education? I mean, processes we can discuss locally, that's fine. Yeah, that's okay.
Yeah, we haven't really hammered out the communication on this, Rasha, sorry.
Okay. Nelson?
No, I think you were just going to wrap up what I was going to wrap
Yeah.
up. So I'll leave you to it. Sorry.
Okay, it's fine. Thank you very much, Susan. Quite insightful. Please don't forget to send in your questions through the Lumio library. So the working group can actually help to prepare the answers on time, right? So we're going to talk more with some of the questions and few demo next week, Wednesday, and hopefully we have more time to discuss more. All right. Thank you everyone for joining, and do have a nice day.
Thanks, everyone.
You too.
Thank you.
Thank you.
Thank you.
Thank you, Susan.
Bye.
Thanks, Sue.